Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. In this special edition webcast, we're going to look at obsessive-compulsive disorder. And on our panel today, we have Dr. Nick de Felice and Dr. Geoff Hooke, who joined Dr. Olga Ward. And they have a look at two scenarios where a patient exhibits varying degrees of obsessionality, and they discuss the best way to manage the patient in that scenario.
Welcome to the program, Geoff and Nick.
Thank you.
I thought today we would look at obsessive-compulsive disorder and the various degrees of obsessions and compulsions. I guess quite a lot of our patients have superstitions like, I'm not going to pass the exam unless I go out of the house on my right foot and, or, you know, look at the sun. But I think this is a really disabling condition in patients who seem to have insight but don't have a lot of innate ability to control it. So maybe we'll start by looking at a patient who's having a reasonable amount of problems but who's still managing to function in her role.
Mrs. Adams, come in.
Thank you, Doctor.
Good day.
Hello.
I'm Dr. Max Kamien. We've not met before.
No, I'm only new to town. So.
What do you like to be called?
You can call me Sally, be fine.
Okay.
Yeah.
Well, what's happening?
Well, my husband has suggested that I come and see you because I have a slight problem with going to the toilet in a public sense. So I'd like to just go to the toilet at home. And my husband is wanting to go on a large holiday. He's taking a year off work. And he thinks that we could have problems when we're on the road. But I've told him that I don't think it's an issue. But I said I'd come and see you and talk to someone about it, so.
So you can use the toilet at home?
Oh, yeah.
But when you go out, you can't?
Well, no, I just don't like to. So I just prefer to duck home and use the toilet there. And
okay, and what don't you like?
I just, they're always so cold and a bit, dirty, and there's always a queue and you always have to listen to other people, all those kind of, things like that.
Okay, so have you ever used someone else's toilet in the last year?
In the last year, no, I don't think I have. No, I haven't needed to. No, I just wait till I go home. I just hold on. And
so if you went out to, let's say you went out to the pictures.
Yeah.
And you felt that you really needed to go to the toilet, what would you do?
I just hold on.
So
I just wait till I get home.
You can hold on that long?
Oh, yeah. Yeah, I've been doing it for a long
and
time.
Has that caused any problems for you?
Well, I have had, my doctor in the last town we were living in suggested that I get a lot of UTIs, and he suggested that maybe they were connected, that I was holding on and not flushing the system out when I needed to, but I just prefer it that way. And I also get a bit constipated sometimes because I...
You get a bit?
Constipated.
Right.
So I probably hold on too long sometimes.
What do you mean by a bit?
Oh, well, often I can't go to the toilet for maybe up to a week for number twos, so, and it can be quite painful.
Okay, so when you see someone else's toilet, what are you frightened of?
Well, I don't know if I'm scared so much. It's just that I can't be 100% sure that the toilet is clean to the way that I like to have the toilet. Now, I keep my house very neat.
Right.
So I'm just not sure when I go to, especially a public toilet, when they've been cleaned. I'm also a bit anxious about who might have been there before me, who was on the other side of the door. Yeah.
So do you think you're going to pick up some sort of bad infection from someone else's toilet?
Yes, highly likely. You see some public toilets.
And what do you think that infection could do to you?
Oh, well, maybe kill me, I suppose, or make me very sick, or unable to look after my children, which would be terrible. That would.
How many children?
3.
3. Do you recognise this is more of a problem than you first said it was?
Well, yes. But I feel like I'm managing and I live my life really happily and...
But if you travelled around Australia, you wouldn't really manage, would you?
Well, I think I would have to. I think I would just have to deal with it. And I'm fairly confident that I would be able to do that.
Would you think it's such a problem that you would accept some help with it?
Well, what kind of help do you think that would be?
Well, help from a psychologist to help you to be less obsessional about your fear of toilets?
Yes, I think my husband would be happy about that if I spoke to someone. And yes, that would be lovely. Thank you.
Well, let's start off with two things. Let's start off with talking about getting you to a psychologist who knows about these sort of things, and let's start thinking about any form of medication, but we don't have to do that at the moment.
Okay.
And I'll put you in touch with, there are a lot of people who have the same sort of problems. You're not alone. And there are groups of people, support groups.
Thank
so
you,
that'll
Doctor.
be the first thing.
Yeah.
And then I'll arrange to see you again in 2 weeks' time.
Okay, thank you.
Okay.
Thank you, I appreciate that. Sounds great.
I'd find this patient quite challenging, even though they seem to be pretty functional and holding down a professional job. What sort of things would you check for in the history, and what things would you chase a little bit more or expand a little bit more?
I think that this is one of those cases which challenge your diagnostic skills in terms of deciding where that boundary is between normal obsessionality, obsessive personality, and obsessive compulsive disorder, and it's sometimes very difficult to make the distinction. I think that in this particular case, what we'd like to do is ask a little bit more about whether there are other areas where she is limited. I mean, she's clearly quite functionally limited, at least socially. Her family want to go on
can't
holidays,
go away. Yep.
and
Yep.
and even going out for dinner is quite a limitation, which in an executive admin assistant might be quite an impairment. So I'd be interested to see if there were other obsessions or compulsions that she had, and maybe even trying to understand a little bit better what the obsessional idea is. What's the irrational idea behind her need to avoid public toilets?
Yes, is it a contamination thing
Fear,
or
yeah.
something else? Yeah.
Okay, so you're looking to see whether this is a germs thing or,
Yeah.
you know,
or
whether it's an exposed, you know, a sensation of being kind of exposed or vulnerable, even in a toilet cubicle.
Yes.
That
Is it
kind
just
of dilemma.
the surface? Is there other maybe mental rituals or mental issues that the person might go through in an OCD sense that we don't know about yet? Is there more to this?
Yes. Yeah.
So Nick, you mentioned obsessionality.
Yes.
And you mentioned obsessive personality.
Yeah.
Could you just kind of give us a few pointers as to what those two might entail and where this patient might fit?
And in this, Olga, I reserve the right to be as vague and woolly as psychiatrists are reputed to be. Okay, so...
So the DSM is vague and woolly?
Well, yeah,
I guess it is.
It is, yeah. So I guess that many people have obsessionality. In fact, it's a quality that a lot of doctors have, which it's actually not a bad quality. In fact, I love that quality in my accountant. I want that quality. There are certain aspects of obsessionality which actually, you know, help with functioning in society. So, you know, carefulness, a need to check,
Attention to detail,
those sort of things. It becomes a personality disorder when it starts to interfere with the person's capacity to function socially or occupationally or whatever. Now, but not in the sense that the person has, you know, strict or clear obsessions and compulsions, which then we're talking about obsessive compulsive disorder, aren't we? But so,
would this be more like the person who, you know, is so focused on like the accountant who's so focused on the detail that they work till 10 o'clock at night just checking and rechecking?
Yeah.
That kind of,
yeah,
that would be kind of in the personality disorder
that's
realm.
right. That's where obsessionality becomes somewhat
but they're managing,
but they're still managing.
There's a point there where they're struggling to manage. They're checking too much, maybe.
Yeah.
Controlling nature, maybe a little bit more.
Yeah.
Trying to control things, whether that's relevant to previous history. It could be.
How does it become a personality disorder?
Well, as I said, when it starts to interfere with the person's functioning in a way as you described, like it's really so well, not extreme, but more to the point where they're not troubled by any particular obsession or compulsion, but they're just not functioning as one would normally expect, I think. And I mean, you don't actually get a lot of people presenting with obsessive personality disorder because they don't actually see a problem with it generally.
Or it has some functional, it almost is a functional
or
part of what they do almost.
Can be functional. As I said, I reserve the right to be woolly, so the distinction between obsessionality and personality, obsessive personality disorder is very vague, I think.
You were talking about that need to control. How does that manifest itself in these kinds of patients?
Well,
like, is it a control of the environment or a control of what they eat or a control of what they do or their
can be all
staff?
Or a lot of those things, actually. It could be a mother controlling how she looks after a child to a very high level, or reducing conflict in a sense in a home or in any environment to avoid those sorts of things, control the environment so that doesn't happen. I think it can be quite broad, quite widespread.
And obsessionality sometimes, obsessionality is a defence mechanism, a coping mechanism that people use to deal with anxiety. So when you have internal turmoil and anxiety, if you can order and organise your external world, it sometimes gives people a sense of being able to, having some degree of mastery of their internal world, you know?
This almost reminds me of talking to some of the little anorexics who just want to kind of get some control of something.
Absolutely.
Rather than everything, that they'll just focus it on what goes in their mouth.
There is certainly a degree of obsessionality in anorexia nervosa, absolutely, no doubt. It's not considered
it's connected to those perfectionistic type traits again, those sorts of things, high standards of performance, maybe self-critical for those sorts of things as well.
So coming back to this quite challenging patient, how common would this type of patient be who's just on the, as you should say, on the borderline of being disabled by her need to use the toilet only at home, but seems to manage in most of her professional settings by modifying her environment.
So, I mean, all I can do, Olga, is in terms of giving you a rough idea, is to say that historically in psychiatry we thought the incidence of OCD was very low in the community because we were basing that on the number of people who attended tertiary clinics, so psychiatric clinics, and I think that the percentage was something like 0.5%. It was a very low percentage, a low incidence of or prevalence of of OCD. When they did the epidemiological catchment area studies in the US, where they sent out people into the community, they found that OCD had an incidence of about 5%. Now, of course, that is somewhat dependent upon how you diagnose it, but I think OCD is much more common in our society, and that's just OCD, let alone obsessionality. So I think that this sort of person often doesn't come to the doctor, except when the family's pushing them to say, we want to go to that local
restaurant. I think
restaurant.
they might actually worry that they're mad or quite unwell and try and keep a lid on it through some basic functioning. But they
or by not mentioning it, because if they mention it, somebody might actually give them a diagnosis they don't want, and that really is a loss of control, isn't it?
Absolutely.
So assuming that this patient came to see you, or that in conversation with this patient something came up that kind of twigged you that they were going down this road, is there anything you could do or say early to kind of head it off or stop it from becoming such an enormously ballooning problem?
I think in this sort of circumstance, you know, you'd be hard pushed to get the person to even consider pharmacological treatments, and I think you're probably going to be more using psychological techniques, don't you think, Geoff? That'll certainly be, you know, more acceptable to this sort of patient.
And probably, like the case, we've got to work quite well with the family, given that there's some motivation on their side as well. And it probably, it certainly needs a large degree of honesty in the patient to follow through on some of the treatments, I think, which may not always be easy if the person's trying to cover and...
Now, are these patients people who are like this from childhood, or are they usually precipitating events? And is there kind of a more common scenario where you could say, you know, after a sexual assault or after a death in the family or after a, I don't know, some other, after going to war and coming back, that they would particularly go down this road?
I think there might be both, actually. I think there's people who've got that personality structure underneath from childhood who then can easily develop something, maybe with a trigger as you described, that then they react by becoming, you know, ritualised in some way to try and order or make sense of something that's difficult to make sense of.
But in terms of then developing OCD, I mean, OCD probably is the condition in psychiatry that we've changed our thinking about more than anything else. So previously we sort of thought there were sort of psychodynamic theories about OCD, thinking about, you know, why a person might develop OCD. Now we know that there's biological changes in the brain of people with OCD. So if she's on the path to an obsessive compulsive disorder, we've probably got that sort of pathology happening in the brain. And it's to do with serotonergic mechanisms in the brain that turn off thoughts. But that's getting more to the OCD spectrum.
But if you were trying to explain this to a patient, you could just say, look, you know, you were born with a certain amount of brain wiring and this just happens to be how your brain is wired. And I like your idea of being able to tell them, you know, this turns off thoughts as well as turning them on.
We don't think about that, do we? But one of the functions of our brain is to turn off irrational thoughts and to take your attention away from them. And I think in OCD that there's a deficit in that mechanism so that the thought just keeps on going around and round and round.
Geoff, for this patient, where would you start? You said with the family and the patient.
I'd like to involve the family just because I think it'll work well that way. The main treatment in this sort of case is response prevention, is the psychological term. And the idea is that the behaviour of coming back home to avoid, if we find out it's a contamination thing, for example, let's say, to avoid that, then we want to stop that response. We want to reduce that response, but if we do stop that response, anxiety typically rises. So we might want to begin with some anxiety management techniques, but then the main focus will be to have a desensitisation hierarchy again. So we'll be wanting to gradually stop these behaviours in a graded way. So probably moving out of the home, maybe, again, depending on the issues, but maybe a friend or a family or a relative's home, trying to expand our horizons, using the family as a support and a coach role, I think, and then setting up a hierarchy to slowly expand that back into the community and hopefully the workplace. And again, it's that anxiety rising, staying in the situation for as long as it takes before the anxiety reduces, and then continuing the exposure program.
In a country situation, obviously this is a little more difficult in terms of resources, but I guess the GP, and if there is visiting community mental health, you could probably manage to kind of support this through. Is there any role for pharmacotherapy in this to knock that anxiety response on the head?
Yeah, look, Olga, there's certainly a role for pharmacological treatment if the person is willing to accept it. And again, without minimising the role of psychological treatments, which are really important, certainly pharmacological treatments are very effective in OCD. And generally we use the serotonergic drugs. So we think that serotonin is the the main neurochemical involved in OCD. So all of the SSRIs are effective, and of course clomipramine, which is a tricyclic with specifically serotonergic properties. Clomipramine is the gold standard of the pharmacological treatment with OCD. The thing about the pharmacological treatment of OCD is if you're going to use the SSRIs, you tend to need higher doses. So whereas, let's say, 20 milligrams of fluoxetine or paroxetine or escitalopram might be the usual dose, the usual adult dose for depression, you're now looking in OCD for 40 milligrams or even 60 milligram doses. So you tend to need to push the dose a bit further.
Yeah. Geoff, if you were trying to give a patient a realistic time frame for kind of getting, I don't know, achieving a goal in this case, I guess this patient, it would be maybe using the loo at Auntie Maud's place, or, I mean, maybe not the loo at the Macca's on the main road or something, but how long would you think it would take for them to get there?
I think it could be anywhere from maybe weeks to months. Depending, I think what it does depend on with this case is the motivation in the individual. I'd be a bit concerned that the individual would say, "Oh, it's actually okay. I can manage going home. It's not a problem. I've dealt with it now for quite some time. I can do it. All right." But the family might be saying, "Well, hang on a second. We can't go out. We can't go travelling.
Yeah, we want to go overseas.
So
you can't take a 24-hour trip
or we
on
want
an
to go
aeroplane.
we want to go to Macca's.
Because it depends how noxious I think it is for the person as to their motivation to change. Something like trichotillomania, which is not actually unpleasant, is very difficult to treat from a psychological point of view.
Pulling out the hair.
If this person feels that, they've got to be wanting to change, I think, to make the speed of recovery really move along. It could drag out otherwise.
Yeah. If you were using an SSRI in the background to maybe manage that anxiety response, again, in terms of timescale, is that something that you think that they would be likely to take long term, or are they likely to take that for like a couple of weeks before they start the psychological therapy, or how does it all kind of work in?
Yeah, no, I think once you engage pharmacological treatment, you're really looking at least months of treatment, because the relapse rate is quite high, and so you do need
so
to
you do your usual 6 to 12 months.
Yeah,
but
definitely, yeah.
Is the patient likely to need to expect to take them for maybe 2 or 3 years, even though they might have like if they've succeeded within the 12 months in kind of gaining some recovery from this, would you continue the treatment?
Well, I think, Olga, you'd be a better person than me if you could get them to take it for longer than that time. And the reality is OCD is a condition that waxes and wanes over time, you see. So I think that it probably is a condition that the patient's only going to take the medication for 6 months, 12 months, then come off it, and then they'll have another episode, and then you'll treat that episode down the track, you know. Of course, the other thing is comorbid depression.
Yes.
And then once that intervenes, then you've got a whole different sort of lot of expectations in terms of prophylaxis about treatment.
The other reason maybe for longer treatment is that if you do get over that episode of OCD, you could easily be replaced with some other obsessionality and ritualisation. That's not uncommon in the terms of a relapse you talk about. It might move into something else.
Can you talk about that a little more?
Well, even though you get past one thing, in the case of, let's say, she can use the toilets, maybe there's some other checking behaviour that comes into play, maybe in the workplace or in the car, or, you know, there's that level of obsessionality maintains itself potentially and could then be...
All right, so that would be something to flag with the patient before you reduce their medication with a view to stopping. Would be, you know, can you get in the car and start it without checking all the lights, the mirrors, the oil levels and the tyre pressures?
And maybe with the family as well would be useful as well.
Yeah.
Absolutely.
So understanding that OCD may not always present with exactly the same content, even though the form of the symptom is the same, the content might be different.
Correct. What would really set your alarm bells off with this sort of patient?
Well, I think that first of all, the development of depression would be something to be really attentive to. I mean, nothing would set my alarm bells off particularly except to sort of note the degree of dysfunction that they experience, and you know, depending on that, so the family and the patient will be distressed, and so you'll then be able to engage them or not engage them in treatment, I think.
Well, this was a fairly functional patient who's kind of just on the borderline of developing something that sounds like an obsessive compulsive disorder.
Yeah.
Let's now have a look at another case where the case scenario where the patient is clearly developing a serious obsessive compulsive disorder with all the bells and whistles.
Yeah.
Come in, Mrs. Adams.
Hello, Doctor. How are you going?
Oh, how do you do? Please take a chair. I'm Dr. Kamien. We haven't seen each other before. Tell me what's happening.
I have would like very much for you to do something about my I read that there was something that you could do to my brain to stop me from being scared of germs.
What are you scared of?
Just everything, everything that is around me that is in the germs, dirt, infection.
What do you think they're going to do to you?
Well, they're going to make me sick, and they're going to get inside me, and I won't be able to breathe, and I won't be able to think properly. And
Okay, how long have you felt like that?
for as long as I can remember.
And what do you do to stop the germs?
Well, I wash my hands constantly, and I try not to breathe air that is contaminated, and I make the children wash their hands, and I don't let anything in the house that has been outside until it's been washed thoroughly, and I make the children take their shoes off and their clothes off when they come home.
How does your husband cope with this?
Well, he does the same. He has to remove all his clothes and his shoes and leave them outside.
So, have you tried to do anything about this?
No, this is the first time I've spoken to someone about it.
And it's completely incapacitating now.
Yes, I can't. I don't sleep very well now because I'm always thinking about if I've forgotten something, if I haven't washed something properly, or if I haven't turned the taps off before I get to bed. I have to get up and double check that everything's off or everything's clean. Must make sure there's nothing left in the laundry.
So, Sully, tell me more about the things that you do.
Well, I wash my hands all the time because I feel like the dirt is in there, and if I don't scrub it hard enough, then the dirt will get further into my arms. It's making my skin very dry and very sore. But I would rather keep washing them than be dirty.
Do you get problems with the skin?
I have, yes, I do now. In between the fingers is very red.
Can I have a look? Yeah, okay, I can see that.
And I take this wherever I go, and that helps me make sure that nothing has got in. And I like to make sure that the kitchen is completely clean and that everything is in its spot. So I make sure that the knives are all in the right spot and the forks are in the right spot and the spoons and just the plates and the plastics and the pots and the pans. And then when the kids have been outside, if they go outside to play or if they come home from school, if they want to come back into the house, I take them round to the back and I have a area set up where I decontaminate them, take off any of the outside germs that they may have got in their skin, so I take their clothes off and I have Pino Clean set up ready to scrub them down.
If you don't do those things, what happens?
Well, I find it very hard to breathe, and I find it quite overwhelming to even imagine that I couldn't do those things. I get very hot, and my chest feels very tight. I also can get very lightheaded and...
Now, you said everything's got to be in its right place.
Yes.
So if one of the children or your husband moved a chair and it wasn't in its right place, what would you do?
Well, I would ask them to leave the room, and then I would place the object back in the right spot, and then move it, and then place it back, and then move it, and then place it back, and then move it and place it back, and then they would be allowed to come back into the room.
Why do they have to leave the room?
Because I would prefer that I make sure that I do it properly, and when they're in the room it distracts me from that.
Mm-hmm. Okay.
And they don't do it properly.
Okay. So does this depress you?
I think I am depressed by it, yes, because I'm exhausted and I just can't think of anything else. And now the children don't want to come home after school. They're always wanting to go to their grandmother's house, and I don't get to see them.
Okay. When I say depress you, has it depressed you far enough to make you want to think that you don't want to live anymore?
Sometimes.
So this has become absolutely incapacitating.
Yes, I don't feel like I can continue for much longer like this, and I think my husband is probably thinking the same thing.
So your husband's just about had enough, has he? And what about the other kids in the other part of the family?
Well, the older boys don't come home very much anymore because they don't enjoy being around me. And my little girl is starting to worry about things too, and not play with her toys, I don't think, the way that other kids play with them.
Okay, so you've come to the stage where you think something really needs to be done.
I think so. I don't want to lose my kids.
Okay, we'll help you do that.
Thank you, Doctor.
This patient sounds like they're very seriously disabled,
Yeah.
and I'm fascinated by the fact that they've managed to draw their family into the whole scenario. How does the family get sucked into this, and how do you rescue them out of it? That was a classic. Over to you. I'll pick on Geoff.
Look, I think it can start very simply, and the family goes along with the first few steps because, oh well, if we do this, maybe it will just quieten down and all things will be good.
Yeah.
But it just keeps going and going, and there's something else there, and before they know it, they're decontaminating at the doorstep.
Yeah.
You can't come in, otherwise it's World War III.
Oh yeah, absolutely.
And full decompensation.
Absolutely.
Yeah.
And that's just not worth it. So the family does bend to the...
Yeah. Now, when you say they decompensate, what sort of decompensation would you see? Do they have screaming matches, or does the person just have a panic attack in front of the family? What's the the reaction that happens?
All of the above. Yeah. They can do a lot. Yeah.
True. And you know, often the family won't recognise it as unreasonable at the start.
Not at the beginning, no.
You know? And so they'll think,
Mum's just a bit funny about hygiene.
She's just a bit obsessional, you know, and
or they've just had some incident. Maybe she's just sort of getting over that a little bit.
Yeah, so they'll
just
have
coming to
those
grips
sort of
with that
thoughts,
sort of problem, you know. Yep.
And then a decade down the track, they find themselves, or 2 decades down the track, they find themselves in this scenario where, you know, they're absolutely...
They've supported the behaviour right along, that it's become normal.
They're captive to the person's obsessive compulsive disorder.
Correct.
Where do you start with them?
I think that in this sort of circumstance, you have to take an approach of, you know, all of the different treatment modalities that you can engage. You know, pharmacological.
Start with the nuclear bomb.
Yeah,
everything.
Yeah, definitely. And you know, in this sort of person, you know, generally, if you can get them to see a psychiatrist, great. Generally, the psychiatrist will want to go through each of the treatment steps in a systematic way, pushing the doses of the medicine, ensuring that there's adequate treatment at each step. So pharmacologically, as I said before, we'd be looking at serotonergic agents. And so if they've had, let's say, an SSRI at the usual standard doses, I would always push it up. That's the first step, you know. So 40 milligrams of paroxetine or escitalopram, or even 60 milligrams if they're not having problems, you know. And then you know, you'd use an SNRI, and you'd make sure that you had a good dose of treatment for an adequate length of time, at least 6-week trials, and then you'd push on to the next drug if it doesn't work to help reduce their symptoms. And then, you know, I would probably pretty quickly go to the gold standard. I mean, why muck around with something that isn't as good? So I'd use clomipramine, and the nice thing about clomipramine is it's a drug where we can do the blood levels. We know we can assay the levels, so we've got a good idea of the therapeutic range in this sort of circumstance. So you'd be wanting to be at the upper end of the therapeutic range in someone like this. And then pharmacologically, the other thing that you often use is you often use major tranquilizers. They will reduce, so antipsychotic drugs, they'll reduce the level of agitation and anxiety, but often the obsessional ideas have become almost delusional. So at this stage, people lose insight into the fact that their ideas are actually irrational, because that's the usual explanation, the usual understanding of an obsession is an irrational idea, which you know to be irrational, but which is associated with increased anxiety until you perform a compulsion.
Do it. That's right. I think one of the starting points with this case has to be a family intervention as well, with an education. I think you've got to involve the system. You've probably got to talk about the family system. If talking about education, you know, this is not going to be an easy process. Everyone's got to be involved in this process. It's taken a long while to develop. It's probably going to take us a little while. Are you up for it?
Yes.
In a sense, you know, are you up for this?
Because they've got a big job ahead of them, haven't they?
Now, if this family has been doing the, you know, decontaminate on the front step thing, and you were talking about intervening with the family, do you say to the family, okay, now do they just immediately stop participating in the whole thing and let the consequence happen?
Well, that would be called flooding, I think.
I think so.
I think that with the family, I think, and maybe with the individual, but certainly I think in that setting, you'd be looking at where to start, and what you're aiming for is a graded, I think you'd have to do it gently, a graded desensitisation or a graded exposure program to gently stop and reduce the rituals and compulsions. But I'd be trying to get everyone on board, and I'd even, you know, do a workshop almost of trying to get a list in some sort of order and series of steps that we would take to work through, and again being mindful and explaining the consequences of each in terms of anxiety to the patient at each step, but that we need to go through it, we need to repeat it a lot, it may be each day, several times, and until we can move through the list gradually.
So it'll often, a program will often involve counting how many times the person, let's say, washes their hands.
Yes.
And if it's, say, 20 times or 40 times or something, you then have an aim of cutting that by 5 every few days or every week or something. Or
exactly. So we take some baseline measures and
step like that.
Exactly right. You can try and reduce that.
Tackle one aspect at a time.
Yeah,
I think so. I'd be guided by the family which way to go, but I'd certainly probably take one aspect. A little bit of mastery would be good if you can have some success in one area, like say the hand washing, where you could bring that down to moderate level. You know, that'd be very encouraging, I think.
Pick off the easiest one first.
Absolutely, in this situation, absolutely, and get everyone. It mimics how we work as a team to do the rest.
And also, it sort of engenders a bit of hope that something can be done about this problem, because by this stage, the family's desperate and feeling hopeless.
This, I mean, sounds definitely not like something that we would be treating in general practice, but obviously this patient can't stay in the city in the clinic forever, nor would it be helpful for them to do so.
No.
How does the GP go about supporting the program?
has to be done in the home. If it's related to the home, it has to be done in that environment. It can't be done really anywhere else.
No, and I guess these patients don't get out of the home very much, do they?
Don't, no.
And so it maybe requires the program being developed and then maybe handing on to the GP or the person in the community that could work with the family, and that could be topped up with the people from Perth maybe.
Now, this patient sounds so seriously disabled. Is this almost certifiable?
Well, sometimes, of course, people with OCD do reach the point where they are psychotic with their illness, and you know, where they're a danger to themselves or a danger to others, they certainly can be certified. I mean, it is a really important step to think about, because usually it's associated with taking the person out of their, well, it is associated with taking the person out of their environment, and flooding treatment occurs immediately. But often it's really, often I don't think that involuntary referral is usually used in this circumstance. I mean, the thing I was going to say is, apart from pharmacological treatment and psychological treatment, you know, this is the sort of case, the severity of this sort of case is the sort of case where we actually think about psychosurgery. So OCD is the one psychiatric condition where psychosurgery is still indicated and considered to be helpful. Now, maybe...
Sounds pretty drastic.
Yeah, no, it is drastic, but these are drastic conditions, and if the, you know, there is a real benefit in it. Now, these days...
they don't just slice your entire corpus callosum or whatever. What do they do?
Well, I don't know the detail of what they do. They're much more sort of precise in what they do, singulotomies and various treatments like that. But there's a little bit of emerging research now about deep brain stimulation in OCD. So that might be a perhaps less destructive psychosurgical technique that might be used. But it's not even done in Australia at the moment. As far as I know, and you know, there's only been a handful of cases reported worldwide. So this is in the early stages. But I guess the point is, people like this are very, very disabled, and you know, even our society recognises this and allows psychosurgery in this circumstance.
Before we leave this whole concept, can I just ask, a lot of children have these very magical rituals, obviously not to this patient's extent, but you know, they've got to, even Christopher Robin would walk on the spaces and not the lines so that the bears wouldn't eat him. I guess that's kind of a common fantasy. When does that actually become an abnormal thing? Do the kids, does it just disappear? Do the kids just grow out of it?
I think probably some do, and that's all good. It depends if something else is a trigger alongside of it, maybe where it goes into a more severe or more, I suppose, more unhelpful, non-functional ritual that definitely does stick out as a problem. Yeah,
but most children will have some obsessional ideas, and as you say, magical thinking that'll manifest in various ways, and that's not to be concerned about, and it's certainly not to be considered to be OCD, and it doesn't mean that they're going to even be obsessional. So I don't think that in children, you know, in young children anyway, you really have to be observing it that closely. However, once they get to puberty, I think you're then starting to become much more concerned, and of course, even in children with very severe obsessional symptoms, well, that's a different story, but we're looking at a different problem there. We're not just talking about the obsessionality that accompanies normal childhood.
No, and quite a lot of the kids with, if not obsessions, at least kind of absolute need for rigid order of things turn out to be autistic or on the autistic spectrum as well.
Yeah, that's right. There could be that sort of problem as well behind the symptoms.
When they become adults, are they any more likely to have an OCD kind of problem?
Yeah, there is a slightly increased risk of OCD in that population. The likelihood of being able to intervene in that sort of problem is really low, I think, because first of all, they don't recognise it as a problem, and so using psychological techniques to manage it is very, very, you know, you need to, if a person's going to deal with their obsessional symptoms, they need to be motivated to make the changes. I mean,
it's very important.
The psychological treatments that Geoff's talking about, you can't impose on someone. They really have to be wanting to do it.
So there needs to be both insight and will.
And
yeah,
will
there needs
to
to
do
be
it.
will,
Yeah,
strong will.
absolutely,
Yeah.
It sounds like it's going to
It's a
be
challenge. Yeah.
a big challenge
Yeah.
for whole teams and over a long period of time. Look, thanks for your input.
Yeah.
Again, any final take-home messages about OCD generally for general practitioners?
I think that OCD is fairly common. It's probably commoner than you imagine in your own practice. It doesn't always require treatment, but there are treatments at least that should be offered to patients. Again, not always with the sort of resounding success that we'd like to see, but nevertheless some success.
And I'm not always sure that people are as open as they might be about the extent of it sometimes,
That's
or
true.
how much it is in the background. And it might be behind other disorders like depression or something like that.
And of course that's the other thing. Always look for depression.
Always look for depression with OCD, and
OCD.
perhaps, given that you guys have said how common this is, look for OCD and depression?
Well,
Yes.
yeah. And again, in that sort of circumstance though, when obsessionality arises as part of depression, you really shouldn't make a diagnosis of OCD. No. It's really depression. You treat the depression, hopefully the obsessionality disappears with that.
Thanks to our panel, Dr. Felice, Dr. Geoff Hooke and our own Dr. Olga Ward. Now, for people suffering from OCD or other anxiety disorders, connecting with other people struggling with the same circumstances can be invaluable. We spoke with some people who are in the process of setting up an OCD support group, and we asked them how to create these networks and what their value can be.
GROW is a support program for people suffering through mental illness or mental health issues. It's a support network for people who are isolated, who don't have any, who are either on medication, but they need a support group for the recovery.
People with mental health issues or suffering anxiety or any kind of relationship breakups or problems all get together once a week and meet for 2 hours where they discuss their issues, and we have a structured program and a method that we go through.
It's a 12-step program, so it's derived from the 12-step Alcoholics Anonymous, which is how GROW initially started back in 1957. There was basically a bunch of psychiatric patients in a hospital, and they were going to AA for support, and they were going to the meetings for about 2 years and finding it really helpful, but thinking that AA wasn't really addressing their mental health issues, so they thought they'd start their own group based on the 12 steps, but to just divert it a bit to be more targeted for mental illness.
People who came out of this, diagnosis of mental illness, it was a huge taboo, and Keogh decided that why not all these people who are so-called have mental health issues come together and find their own solutions, and that worked out better than finding solutions from psychiatrists or psychologists. Reason being because it was a brainstorming of few people who are going through that experience, they can relate to each other, and they designed a program, a 12-step program, as you can see, and that's working until today. There's always addition, and we add things and we delete, but it's basically the core, the essence of GROW is being inclusive and helping each other, and we create leaders and we give them the opportunity. People who come, every time there'll be different person who would be leading the group, so they get empowered. That's how they come, and that's how they recover.
And GROW is fully confidential, it's fully free, we're self-supporting, we run by our own donations. And like Zoe said, it's peer support, so we don't have trained counsellors, we don't have psychologists, doctors, we're just people with a mental illness who come together and support each other.
And there's no stigma attached to within the groups, because everyone's going through their own thing.
And we don't talk about diagnoses, so or medication. Or medication, so it's, and you don't even need to have a mental illness to come to GROW. You might just be struggling with life issues, or you might be lonely and you just want to come, and and it's like a program for living, really.
Yeah, it is.
We have a lot of our clients who started requesting for OCD group, especially someone suffering through OCD. When they are diagnosed by OCD, they want to actually meet people who have OCD, and people who have heard of GROW, they wanted to come together to start a group. That's why we started this OCD group just on their request, and hopefully it will work for them. We have a lot of our client consumers who are actually going through OCD, and they're going through normal different groups, but they, and plus people from outside, they wanted to come together in just the specialized group.
I find some of the benefits are self-development, self-growth, self-esteem, positive people around you, making friends, socialising. We have a lot of social events that we do. Yeah, I find it just really encouraging and beneficial for mental health.
So it's kind of an avenue for them to actually display their art, display the social side, have tea or coffee, and just able to chat about their problems casually. And then when they listen to the practical solutions from people who have been in their situation, and practical solutions which are in layman terms, not some psychiatrist or psychologist using medical terms, but someone who's been in that situation and telling them, oh, I felt the same and I tried this, and why don't you try this?
Yeah, and I think it's also helpful in breaking isolation as well. A lot of people with mental illness are isolated, they're alone, they're abandoned, they're stigmatised by society. When they come to a GROW group, they can feel like they belong somewhere, that they're understood. A lot of the time when you might visit a psychologist or psychiatrist, they might understand, but not on that same level because they don't actually experience them themselves. And a lot of growers say that's what they get the most out of groups, is that peer support of being able to share with people who understand what it's like to have a mental illness. And it's also similar to cognitive behavioural therapy as well, so it does teach us to act better than we feel, you know, to not go by our imaginations, or just because I might be depressed and don't feel like getting out of bed one morning, I can still get out of bed even though I feel depressed, you know. And the support of the group gives you accountability, and the group will say, you know, this week why don't you practice trying to get out of bed in the morning, and they'll give you a piece of program, and then you'll come back next week and they'll ask you how you went, and you can report back to the group and say, yep, you know, there's been a few times this morning where I've got out of bed. And so it's a real good accountability support.
And not only that, we also make sure we look after each other. So once a week or twice a week, they would be given a phone call just to check by another grower to see if they're okay. So there are a lot of benefits, and we've had a research by independent researcher, and it's working because it's one, not just it's inclusive socially, but it's also a practical way to find solution to their problems.
If you have GROW pamphlets, if a GP has GROW pamphlets, and they can talk to their patient about GROW and suggest that they go along, and all that a patient would need to do is call our office and say, I'm interested in coming to a GROW group, and they'll give you information, because we've got groups all over Perth, all different suburbs, day, night times, so whatever's most convenient for a person to come along to.
Yeah, they can go to their closest group or whatever.
And you don't actually need a referral in terms of, you can just come and walk into a GROW group. You don't need a piece of paper to say I've been referred by the doctor to come. You can just walk off the street, come into a GROW group and say, hi, my name's this is my first group, and you'll be welcomed.
We have these days, we have a Facebook, GROW WA Facebook. They can be a part of GROW WA Facebook. Then we have a lot of articles, and we also have a lot of networking. We have a partnership with different communities and support networks. So for example, they're in Albany, and we don't have a group in Albany, but we can refer them to our partners in Albany, like Depression Support Group, and see if they can go there. And we have, and if there's enough interest, for example, in a rural area, and if there are 7 or 8 who says yes, they want to start a GROW group, it's not a rocket science. We can go there and we can start a GROW group. The good thing about GROW group is it's actually run by growers. It's run by volunteers, so it's not something that we have to be there all the time. We'll come and we'll set it up, a GROW group. It's completely free. It's 2 hours. It's tea and coffee, and we can arrange and we can coach them how to lead the GROW groups. So you need minimum 5 people to start a GROW group.
There's no limits to grow, only the limits that you set yourself. I encourage each and every person to give it a go, at least come for 3 meetings to try and see what it's like. You'll make friends, you'll have support, it's really worthwhile.
This doesn't need to be just for OCD or mental health issues. People who are suffering, who are finding, financial problems, or they are stressed, they have anxiety, so anyone can come and be a part of a growth community. It's actually school of living. We say at Grow that we teach them the life skills. We teach them how to not worry for little things, how to live life much healthier way. We have a partnership with Act, Belong and Commit, and we encourage people to look after their life and go out for walks and to socialize in their community. So we can help a lot of people in rural area once they want to become a part of Grower, or even just use our website, and if they're ever in Perth, they can attend one of the meetings. Because it's voluntary, it's free, so it's all inclusive. So everyone is welcome to join us, or even just look into or explore what Grow is about.
And thanks again to all our guests in tonight's show. That's all the time we have for in this program. Remember, if you want to review this program or any of the other programs, they're all available on our website at ruralhealthwest.com.au. We'll be back next time on the 2nd of July with the program looking at X-rays and imaging. I'm Jerry Gannon. Thanks for joining us.